Hello everyone, this is Dr. Sangeeta Chaudhary and again I welcome everyone to my lecture class. In my today's class, again I am going to discuss a very important topic, that is the diagnosis of tuberculosis. That means how we diagnose a case of tuberculosis. It is very important that we know how to diagnose tuberculosis, because once we know the diagnostic protocol and we diagnose a case, then only we can start the treatment on time and we can save the life of a patient. So let's begin. Let's talk about the diagnostic protocol, how we diagnose a case of tuberculosis. So before we begin with the diagnosis of tuberculosis, we need to know about certain case definition. So let's talk about the case definition first, and then I'll discuss about the diagnostic algorithm or the diagnostic protocol. Now, there is something known as bacteriologically confirmed tuberculosis. Now, what it is? It refers to a presumptive TB case from whom a biological specimen is positive for acid-fast bacilli or positive for Mycobacterium tuberculosis on culture, or positive for tuberculosis through rapid diagnostic molecular test. That means bacteriologically confirmed tuberculosis, we will say, if we get a positive sample through the smear examination, or maybe through culture, or maybe by CB-NAT, that is the rapid diagnostic molecular test. Now, there is something known as clinically diagnosed tuberculosis. As the name suggests, clinically diagnosed tuberculosis, that means there may not be any microbiological confirmation of tubercle bacilli from the sample of the patient. So, clinically diagnosed tuberculosis refers to a presumptive TB case who is not microbiologically confirmed but has been diagnosed with active TB by a clinician on the basis of X-ray abnormalities, histopathology from the sample, or clinical signs, with the decision to treat the patient with the full course of anti-TB treatment. So that means clinically diagnosed TB means someone who does not have any positive sample for acid-fast bacilli, but his or her X-ray is suggestive of tuberculosis, or he has some clinical signs because of which the clinician decides to give a full course of anti-tubercular treatment. So that is about the bacteriologically confirmed TB and clinically diagnosed tuberculosis. Now let's talk about the presumptive TB definitions. Okay, we'll not talk about the previous guidelines, but I have just shown this for the comparison. Now, about the new guideline, as per the new guideline, what is a presumptive TB case? Presumptive TB case refers to a person with any of the symptoms and signs suggestive of tuberculosis. So what are the signs? Cough for more than 2 weeks, fever for more than 2 weeks, significant weight loss, hemoptysis, or any abnormality in the chest radiograph. Okay, so any of the symptoms and sign present, we will think about a presumptive TB case. Cough, fever for 2 weeks, significant weight loss, hemoptysis, or any abnormality in the chest X-ray. Now, what is presumptive drug-resistant tuberculosis cases? Again, I will not go into the detail of the previous guideline, but I have just shown this for comparison purpose. About the new guideline, okay, when we will call a person as having drug-resistant tuberculosis, it refers to the patient who is eligible for rifampicin resistant screening at the time of diagnosis itself, or and during the course of treatment for drug-sensitive tuberculosis, or isoniazid mono or poly resistant, and includes following patients: all notified TB patients, follow-up positive on microscopy including treatment failure. Okay, now this is about the drug-resistant tuberculosis cases. Okay, now if we talk about the pediatric tuberculosis, what is the presumptive pediatric TB? Okay, it refers to children with persistent fever for more than 2 weeks like adult, cough for more than 2 weeks like adult, loss of weight or else no weight gain, and or history of contact with infectious TB cases. In a symptomatic child, contact with a person with any form of active tuberculosis within last 2 years may be significant. Okay, and there may be history of unexplained weight loss or no weight gain in past 3 months. Okay, so this is about the presumptive pediatric TB case. When we say significant weight loss, that means weight loss of more than 5% of the body weight, right? Now, what is extrapulmonary tuberculosis? Okay, we all know that tuberculosis, anatomically it can be pulmonary or extrapulmonary. As the name suggests, pulmonary means tuberculosis in the lungs, and extrapulmonary means tuberculosis elsewhere, not in the lungs. So, what is extrapulmonary TB presumptive case? So, it refers to the presence of organ specific symptoms and signs. That means whatever organ is involved with tubercle bacilli, okay, symptoms pertaining to that organ should be present to call it as presumptive extrapulmonary TB case. Now, if there is involvement of the lymph node, there will be swelling of lymph node and pain. Okay, bone TB, there will be swelling in joints, neck stiffness or disorientation in cases of tubercular meningitis, and constitutional symptoms like significant weight loss, persistent fever for 2 weeks or more, and night sweat. These are the very important constitutional symptoms. So whenever we take history, we need to ask about these constitutional symptoms as well to find out if there is any extrapulmonary tuberculosis or not. So this was about the different definitions of tuberculosis. Now, if we talk about the tests, so what are the tests we usually use for the diagnosis of tuberculosis? Okay, first of all, we do smear examination. Okay, smear examination of the sample, smear microscopy, where we look for the acid fast bacilli. Okay, there are certain rapid molecular diagnostic tests, okay, like line probe assay LPA for Mycobacterium tuberculosis complex and detection of rifampicin resistance and isoniazid resistance, and fluoroquinolone and SLI resistance. Nucleic acid amplification test, which is also known as CB-NAT or TrueNAT. CB stands for cartridge based nucleic acid amplification test, which is also known as TrueNAT. So these are the rapid molecular diagnostic tests. So other than smear microscopy, we can also go for culture. Okay, culture to identify the acid fast bacilli from the sample. So smear microscopy, culture, and then rapid diagnostic tests like LPA and CB-NAT. So these are the diagnostic tests we use or diagnostic tool we use. Other diagnostic tools may be radiography, that is the chest x-ray we can do, serological test, tuberculin test, and interferon based gamma release assay, not to be used for diagnosis of tuberculosis. Okay, so when are these to be used? These are actually used for identification of latent tuberculosis. Okay, latent tuberculosis identification is done by tuberculin test and interferon gamma release assay based test, not for the diagnosis of active tuberculosis. Just to mention that smear microscopy is more specific and has less inter and intra-reader variability than X-ray. Okay, so this is about the tools or tests we use for the diagnosis of tuberculosis. Lastly, coming to the diagnostic algorithm for drug-sensitive tuberculosis. Now, how we proceed for the diagnosis of drug-sensitive tuberculosis. First of all, we need to find out who is a presumptive TB patient. So, if the patient is following the criteria as I have mentioned above, we will call the patient as presumptive TB patient. Now, first of all, we need to do a smear examination, and we will also do a chest x-ray. In smear examination, if the case is smear positive and chest x-ray suggestive of tuberculosis, then we will label the case as microbiologically confirmed tuberculosis. Smear positive but chest x-ray not suggestive of tuberculosis, then also we will call the case as microbiologically confirmed tuberculosis because the smear is positive for acid-fast bacilli. Smear negative but chest x-ray suggestive of tuberculosis, then we will go ahead and do a CB-NAT for the confirmation. Smear is negative or not available and chest x-ray not suggestive of tuberculosis, but clinical suspicion is high, then again we will go ahead and do a CB-NAT. For patients with HIV, people living with HIV/AIDS, for them we will directly go ahead and do a CB-NAT. CB-NAT stands for cartridge-based nucleic acid amplification test. Now, if via CB-NAT MTB is detected and rifampicin sensitive, then again we will call it as microbiologically confirmed tuberculosis. If rifampicin resistance is indeterminate, we will repeat the CB-NAT on second sample. Again indeterminate on second sample, then we will collect fresh sample for culture or line probe assay. If via CB-NAT MTB detected and rifampicin resistance is identified, then we will refer the patient for management of drug-resistant tuberculosis. If via CB-NAT MTB is not detected or CB-NAT result is not available, we need to consider alternate diagnosis and refer to a specialist. Okay. In that case, if the clinical suspicion is still high, we will consider the case as clinically diagnosed tuberculosis. And if there is no clinical suspicion, then we can make an alternate diagnosis. So this is the protocol for the diagnosis of tuberculosis in short. That means we get a presumptive TB patient, we need to do two things: smear examination, chest x-ray. Smear is positive, then anytime we will call the patient as microbiologically confirmed tuberculosis. Smear negative, we will take the help of chest x-ray. Chest x-ray suggestive, then we will go ahead with CB-NAT. Okay, and via CB-NAT again, if MTB is detected, we will call as microbiologically confirmed tuberculosis if rifampicin is sensitive. Rifampicin resistance, we will refer the case for the management of drug resistant tuberculosis. Okay, rifampicin resistance indeterminate, we will examine second sample and we will do the repeat the CB-NAT. Even after everything, nothing is positive, means no smear positivity, no x-ray positivity, CB-NAT also not available. Okay, then in that case, if the clinical suspicion is high, we can diagnose the case as clinically confirmed tuberculosis or clinically diagnosed tuberculosis. And depending on the diagnosis, we can go ahead and start the treatment. So this was all about the diagnosis of tuberculosis. Okay, I have discussed about the case definitions, then diagnostic methods or diagnostic tools we use, and the algorithm for the diagnosis of drug sensitive tuberculosis. So thank you so much for attending the class. Now let's talk about the diagnostic algorithm for extrapulmonary tuberculosis. Okay, we have talked about the extrapulmonary tuberculosis presumptive patients. Okay, the patients who has symptoms pertaining to different organ involved. So presumptive extrapulmonary TB case, we will take sample from the site involved. So appropriate specimen from the site we will try to collect. If sample is available, then we will go ahead and do a CB-NAT again. MTB, Mycobacterium tuberculosis detected, rifampicin sensitive, then it is again considered as microbiologically confirmed extrapulmonary tuberculosis. Rifampicin indeterminate, like before, we will repeat the CB-NAT on a fresh specimen. If still indeterminate, we will go ahead with culture. Rifampicin resistance, then we will refer the case for the management of drug resistant tuberculosis. Now via CB-NAT, MTB may not be detected also, but if the clinical suspicion is high, then we need to follow the algorithm for high clinical suspicion, like before I have mentioned. Now, if sample is available but CB-NAT is not available, means the CB-NAT facility is not available everywhere. So if the facility is not available, then we can go ahead with liquid culture. If culture is positive, then we will consider it as microbiologically confirmed extrapulmonary tuberculosis. If culture is negative, we will consider the patient as having no tuberculosis. Now, sometimes the sample itself may not be available from the involved site. Then what to do? If the sample is not available but the clinical suspicion is high, then we need to use other diagnostic tools. Okay, and then if diagnostic tools are helpful, we will be able to make an alternate diagnosis. Otherwise, if the clinical suspicion is high, we will consider or label the case as clinically diagnosed or clinically confirmed tuberculosis. So this is about the diagnostic algorithm for extrapulmonary tuberculosis. Okay, so we always need to keep in mind first the case definitions of pulmonary tuberculosis, presumptive pulmonary TB and presumptive extrapulmonary TB, and then depending on our suspicion, we need to go ahead with the diagnostic algorithm. Now, if we talk about the algorithm for the drug-resistant tuberculosis, how we are going to proceed, let's see. Okay, all notified TB patients, presumptive tuberculosis, and non-responder to treatment, what we need to do? We'll go ahead with a nucleic acid amplification test. If rifampicin resistance is detected, then we will do drug sensitivity test. Okay, we will do line probe assay and liquid culture drug sensitivity test for first line and second line drugs. Presence of non-drug sensitivity test based criteria and or resistance to these drugs. Okay, if no, then we are going to use a shorter MDR TB regimen. Okay, if drug resistance is present for these, then we are going to use all oral longer MDR TB regimen. Okay, if rifampicin resistance is not detected, okay, then first line treatment is started. Then for first line probe assay is done to find out the resistance pattern. If isoniazid resistance is detected, then again second line probe assay for second line drugs, okay, and liquid culture drug sensitivity test has to be done. And then all oral isoniazid mono or poly resistant drug resistant tuberculosis regimen to be started. If isoniazid resistance is not detected, then continue the first line treatment. Okay, and then we may modify the treatment also depending many other criteria. So basically for the drug resistant TB algorithm, we need to do nucleic acid amplification test, which will help us to identify if there is any rifampicin resistance or not. Rifampicin resistance is detected, then we are going to do drug sensitivity testing, that is DST for first and second line agents, and depending on the reports of drug sensitivity testing, we are going to give either shorter regimen or longer regimen. Okay, and if rifampicin resistance is not detected by NAT, then we're going to prescribe the first line treatment, and then we're going to do a line probe assay to identify isoniazid resistance. If isoniazid resistance is detected, then again we're going to do drug sensitivity testing for second line drugs, and then we need to use the isoniazid mono or poly drug resistant tuberculosis regimen. And isoniazid resistance if not detected, then we may continue the first line treatment as we have already started. So this is about the integrated drug resistant tuberculosis diagnostic algorithm and treatment algorithm as well. Anyway, in my other class I have already discussed about the management protocol of drug resistant tuberculosis. Lastly, let's talk about the diagnostic algorithm for pediatric pulmonary TB. I have already discussed about the case definition of presumptive pediatric TB, that means persistent fever for 2 or more weeks without a known cause and or unremitting cough for 2 weeks or more and or weight loss of 5% in 3 months or no weight gain in past 3 months with history of contact. In these cases, we're going to do a chest x-ray. If chest x-ray is highly suggestive and patient is expectorating sputum, or from gastric aspirate, we need to do a CB-NAT. If CB-NAT is positive, it will be considered as microbiologically confirmed TB. CB-NAT positive skin test, CB-NAT negative skin test positive. If there is no other likely alternate diagnosis, we will consider the case as clinically diagnosed TB case. CB-NAT negative, skin test negative, both are negative, then we need to look for alternate cause. If in the chest x-ray there are shadows or chest x-ray not available, skin test positive or not available, we need to give a course of antibiotics and we need to repeat the chest x-ray to look for the shadows. If the shadow is persistent and symptoms are present, then again we need to examine the expectorated sputum or gastric aspirate for CB-NAT. CB-NAT is negative and skin test positive, okay, then no other likely alternative diagnosis is there, we can consider the case as clinically diagnosed tuberculosis. If CB-NAT is positive, then it is a case of microbiologically confirmed TB. Okay. If CB-NAT is negative, skin test negative, both negative, then we need to refer to expert for workup of persistent pneumonia. If chest x-ray is normal but skin test is positive, then evaluate for extrapulmonary tuberculosis and we may refer the case to an expert. If chest x-ray is normal and skin test is negative, then definitely we need to look for the alternate cause. So this is about the simple diagnostic algorithm for pediatric tuberculosis, pulmonary tuberculosis, where we need to do a chest x-ray followed by a CB-NAT and then skin test. And with these three modalities, we can identify a case of tuberculosis, okay, pediatric tuberculosis. So thank you so much for attending the class.